Welcome everyone. This is the third part of our mixed bag MCQ discussion. Right. We shall move on to the first question. A 10-year-old child presents with sudden eruptions of multiple small 0.5 centimeter to 1.5 centimeter drop like erythematous scaly papules over the trunk and limbs. The mother mentions a severe sore throat 2 weeks ago. What is the most likely diagnosis? So we got a sore throat. Sore throat is followed by drop-like erythematous papules over the trunk and limbs. So if we look into the options, pityriasis rosea. In pityriasis rosea is not associated with sore throat. Remember that pityriasis rosea is not associated with sore throat, right? And if we talk about the lesions in pityriasis rosea, right, we first get a herald patch. We get a herald patch, and we have and the distribution is in a Christmas tree pattern. So nothing has been mentioned. So pityriasis rosea is not our answer. If we talk about gutted psoriasis, yes, gutted psoriasis does occur after a sore throat. It occurs in children. And we do get drop-like lesions. The drop-like lesions are usually seen in the trunk and proximal limbs, which is mentioned in this question. So this is characteristic of gutted psoriasis. Okay. If we look into the other options, pityriasis lichenoides chronica, as the name suggests, it is due to a chronic recurrent. It is a chronic recurrent condition, and again, it is not associated with sore throat. Okay. And secondary syphilis in a 10-year-old child is extremely unlikely, and moreover, secondary syphilis involves your palms and soles, okay, not your trunk and limbs. Okay. So answer over here would be option B. Moving on to the next question. You have attempted to intubate a patient twice. Both the times you obtained a Cormac-Lehan grade 3 view and failed. The patient's oxygen saturation is now dropping to 84 despite bag and mask ventilation. What is the next most appropriate step according to the ASA difficult algorithm protocol? Now we were trying to intubate the patient, but all the time we are getting this Cormac-Lehan grade 3 view, right? This is the view described, or the view of the glottis that is described while intubating a patient. Cormac-Lehan grade 3 means only epiglottis. Excuse me. Only epiglottis is visible, right? And something that we need to know that Cormac-Lehan grade 3 and grade 4 are difficult to intubate. Right? That's why we failed to intubate the patient twice. So what is actually the algorithm? If intubation fails twice, whatever be the cause, then we should directly move on to face mask ventilation. Okay. Now if this face mask ventilation is inadequate, then the first thing that we should think about is to go for a supraglottic device. Supraglottic device, most commonly in the form of an LMA. Okay. Now if LMA is not available, or if LMA has failed, LMA usually does not fail, but if LMA fails or if LMA is not available, then we would directly go for an emergency invasive airway, right, in the form of a cricothyroidotomy or tracheostomy. Okay. So this is the sequence that we follow. Over here, twice we have failed, and we have started with bag and mask ventilation, but the saturation is dropping to 88, which means that face mask ventilation is inadequate. So we should go for supraglottic device like LMA. Option D should be our correct answer. Okay. If we look into the other options, attempt a third intubation with a smaller ETT. Over here, the size of the ETT doesn't matter. If you are not getting a proper view and you are failing to intubate, then the size doesn't matter. Even with a smaller ETT, the view won't improve. Perform an immediate emergency cricothyroidotomy. Now this would occur if LMA fails or if LMA is unavailable. Okay. And administer more muscle relaxant. Again, providing more muscle relaxant would not improve the grading. Okay. So answer over here would be option D. Moving on to the next question. Now, which of the following are principles of chlorination required for effective disinfection of drinking water? Okay. Chlorination is quite an important topic for both the exams. Okay. So water should be clear. turbidity should be less than 1 NTU. Yes, this is a true statement. It should be clear. Why clear water? Because suspended particles, if we have suspended particles in water, they actually protect the microbes. They actually protect the microbes from chlorine, from the free chloride or OCl or whatever chemical is found in the water, right? HOCl, OCl, chloride, that all those things which kill the microbes, they will be protecting them, the suspended particles. The turbidity, desired turbidity should be less than 1 NTU. NTU means nephelometric turbidity unit. Okay. Chlorine demand must be met. Yes, this is a true statement. What is chlorine demand? What is chlorine demand? If we talk about chlorine demand, is actually the amount of chlorine added. It is the amount of chlorine added to the water body minus the amount of residual chlorine. This is the chlorine demand, right? This has to be met, and this residual chlorine, this has to be met first, and then we have to add extra to get a residual chlorine value of at least 0.5 milligrams a liter, right? At least 0.5 milligrams a liter. Okay. And this residual chlorine has to be kept for a period of at least 1 hour. And this 1 hour is actually known as the contact time. Okay. So first we add chlorine to get rid of all the organic substances, which are responsible for the chlorine demand. After that, after completing it, we would add more chlorine to get a residual concentration of more than 0.5 milligrams a liter, and we would keep it for 1 hour, which is known as the contact time. Okay. So if we read the other options, contact time must be at least 15 minutes. No, it should be at least 1 hour. Free residual chlorine of 0.5 milligrams a liter should be present for 1 hour. Yes, this is a true statement. So the answer over here, A, B and D are correct. Option B should be our answer. Okay. Moving on to the next question. Right. An 8-year-old boy presents with easy bruising, massive splenomegaly and chronic bone pain in his thighs. Radiograph shows a characteristic deformity of the distal femur as shown in the image below. A bone marrow aspirate shows large macrophage with fibrillar cytoplasm. Which enzyme is deficient in this patient? So in this image we can very well appreciate this is the Erlenmeyer's flask sign. Okay. We have Erlenmeyer's flask sign. Besides that, we have easy bruising, massive splenomegaly, right? This massive splenomegaly is due to thrombocytopenia and thrombocytopenia. Massive splenomegaly has resulted in thrombocytopenia. Thrombocytopenia causes easy bruising. Besides that, we have this Erlenmeyer flask deformity, and something important that has been mentioned, that the bone marrow aspirate is showing us large macrophages with fibrillar cytoplasm. This is actually the characteristic description of a Gaucher cell, which has a crumpled paper appearance, right? We all know how it looks, right? Like this crumpled paper appearance image has been given like 3 to 4 times in the previous year exams. So this crumpled paper appearance is actually due to this fibrillar cytoplasm. Okay, so this total combination of this easy bruising, massive splenomegaly, chronic bone pain with this radiographic finding of Erlenmeyer's flask sign, then Gaucher cell, everything points towards a diagnosis of Gaucher's disease. Right, Gaucher's disease, and we all know Gaucher's disease is due to deficiency of glucocerebrosidase. Okay. This lysosomal storage disease are extremely important, right? Just diagnosis are important. Okay. If we talk about the other options, aryl sulfatase A deficiency leads to metachromatic leukodystrophy. Sphingomyelinase leads to Niemann-Pick disease, and this alpha galactosidase deficiency leads to Fabry's disease. Okay, so over here, this is Gaucher's disease due to glucocerebrosidase deficiency. Okay. Moving on to the next question. A 45-year-old female presents with the following deformities as shown in the image below. On examination, which of the following joints is characteristically spared in this condition? So we have two findings. Over here, we can very well appreciate we actually have a flexion deformity. We actually have a flexion in the proximal interphalangeal joint, and over here we have extension. Over here we have extension in the distal interphalangeal joint. Okay. So this is the characteristic Boutonniere deformity. Okay. And over here we can see the nodule in the elbow. This is a rheumatoid nodule. rheumatoid nodule. What is a rheumatoid nodule? It is actually a painless granulomatous nodule, right, which is most commonly seen in an elbow. Elbow is the most common site, followed by the finger joints, This is also rather the most common extra articular manifestation in rheumatoid arthritis, the rheumatoid nodule. So with both the findings, we are very much sure that the condition is rheumatoid arthritis. The question is, which of the following joints is spared in rheumatoid arthritis? It is the DIP joints which are spared in rheumatoid arthritis. Remember that. Okay. Over here, this extension in the DIP, the swan neck deformity, the bottom ear deformity. Those deformities are actually not due to involvement of the joint. These things are due to ligament injury. These involvement are due to ligament injury, not the joint involvement per se. Okay. So answer should be option A, DIP. Okay. Just a second. Extremely sorry for the cut. Let's continue with our discussion. Right. The next question says a 35-year-old HIV positive patient with a CD4 count of 120, presents with fever and cough. Now HRCT shows a tree in bud appearance. Which of the following is the most appropriate next diagnostic step according to the NTEP guidelines? So over here we have a HIV positive patient with fever and cough, and the question itself is directed towards the diagnosis of TB, right? Remember that this tree in bud appearance is actually a very non-specific finding. This tree in bud appearance is due to endobronchial spread, right? It can be anything, right? It is due to distal airway involvement, distal airway involvement. It can be due to anything. It can be due to a lot of things. Okay. But the question is directed towards TB. The question wants to test us about the diagnostic protocol, right? Something important that we need to know in a normal individual. What I mean by normal is that people who are not suffering from HIV, who are not HIV positive. For them, we would start with chest X-ray and sputum smear. And then as per the finding, we would go for CBNet. But for people living with HIV, we directly go for CBNet. This is something which the question wants us to know. Over here, the patient is HIV positive, so we would directly go for CBNet or sputum and not go for sputum smear. Okay, not even culture. An empirical treatment with broad spectrum antibiotics has no role. Okay. Option C should be our answer. People living with HIV, we would directly go for CBNet, no chest X-ray or sputum smear. Okay. Moving on to the next question. A 32-year-old woman with primary infertility has a 4 cm Figo type 2 fibroid. She is scheduled for surgery. Which surgical approach is most appropriate for this specific patient? Now remember that for the management purpose, we actually divide fibroids into two groups. One is submucosal, and the second one is non-submucosal, that is the intramural and subserosal ones. For the others, we go for medical management, right? But over here we are talking about the surgical management. Okay. The submucosal group is further divided into two more groups. In the first group, we have type 0 and type 1, and in the second group, we have type 2. Okay. Type 1 means less than 50% of intramural involvement, is present. Okay. And type 2 means more than 50% of intramural involvement is present. Okay. For type 0 and type 1, we go for hysteroscopic myomectomy. Excuse me. Okay. Whereas for type 2, again we have two modalities depending on the size, right? If the size of the fibroid is less than 5 centimeters, then we would go for lap myomectomy. Whereas if the size is more than 5 centimeters, we would go for abdominal or open myomectomy. Okay. So over here the question says it's a 4 centimeter type 2. Type 2 may less than 5 centimeters, so we would go for lap myomectomy. So our answer over here should be option D, laparoscopic myomectomy. Okay. This is the surgical protocol that we should know, right? First dividing them into type 0, type 1 and type 2. Type 0, type 1 may hysteroscopic. Type 2 may, depending on the size, if less than 5 centimeters, laparoscopic, more than 5 centimeters, abdominal or open myomectomy. Okay. Moving on to the next question. Which of the following statements is incorrect? Regarding ABO blood grouping. Okay. antibodies are naturally present since birth. No, this is a false statement. Antibodies actually do take time. They take 3 to 6 months time to develop, and they develop due to exposure to environmental antigens like the gut bacteria, or even food particles, food antigens. Okay. The antibodies are predominantly IgM. Yes, this is a true statement. The antigens are carbohydrate in nature. Yes, this is also a true statement. To be precise, they are oligosaccharides. Antibodies are present only if antigens are absent. Yes, this is also a true statement. Of course, those who are having the A antigen will never have the A antibody. Otherwise, they will cross react. This is to prevent cross reaction. So, incorrect statement would be option A. They are not present since birth. They do take 3 to 6 months time to develop. Okay. Moving on to the next question. Now, a 5-year-old child presents with a history of recurrent fractures following minimal trauma. On examination, the child has distinct blue sclera and normal appearing teeth. The PTA finding is shown in the image below. What is the most likely type of the condition the patient is suffering from? Now we are getting blue sclera. Blue sclera has some problem in hearing. That's why a PTA finding has been given, and recurrent fractures in a 5-year-old child. This recurrent fractures, blue sclera, child, and hearing loss. The condition is osteogenesis imperfecta. Excuse me. The condition is osteogenesis imperfecta. Okay. Now, certain important things to remember over here. What we can see in this PTA, we can see in the right ear we have a airborne gap. Is present even in the left ear. And if we talk about this masked finding, this masked hearing is normal. Masked hearing is normal in both of them. So we are getting completely only conductive hearing loss, no sensory component, only conductive hearing loss in both the ears. So this PTA finding is a bilateral conductive hearing loss. Okay. Bilateral conductive hearing loss. Right, now we need to define the type. Right, remember that there are a lot of types. There are many types of osteogenesis imperfecta, of which 4 are very important. Right, type 1 to 4 are important. How to differentiate between them? If we talk about the types of osteogenesis imperfecta, first we divide them into 2 groups. The one with a blue sclera, and normal teeth, and the second category with a normal sclera and involved teeth. Right, we have something called the dentinogenesis imperfecta or something. This teeth finding is actually known as dentinogenesis imperfecta. The teeth lesion is known as dentinogenesis imperfecta. So 2 categories: blue sclera, normal teeth, and the second category is normal sclera, dentinogenesis imperfecta, teeth lesions. Okay. Now each of these is divided into 2 categories based on whether they have associated conductive hearing loss or not, whether it is present or absent. Okay, both the categories. Now, in a blue sclera normal teeth, if conductive hearing loss is present, that is type 1. In a blue sclera normal teeth, if conductive hearing loss is absent, it is type 2. In a normal sclera involved teeth, if conductive hearing loss is present, it is type 4. And if it is absent, it is type 3. This is how we differentiate between the 4 most common types of osteogenesis imperfecta. Certain important things to remember among these types. Type 1 is the most common one and is the least severe. Type 2 is the most severe variety. The child is going to die before 1 year of age. Okay. Over here, the question has mentioned about a conductive hearing loss. We have bilateral conductive hearing loss. We have blue sclera. Blue sclera bilateral conductive hearing loss present, which means it is type 1. Okay. This is how we differentiate between the types of osteogenesis imperfecta. Okay. Moving on to the next question. Which of the following statements about the given pattern of inheritance is false? Now over here we can see that the mother is affected and all the children are affected. And again, mother is affected and all children are affected. Again, the mother is affected, all children are affected. But if the father is affected, none of the children are affected. So this suggests us that the pattern is a mitochondrial inheritance. Okay. Right, it could have been autosomal dominant had all these 3 were also involved. If these 3 children were also involved, which means that it would have been autosomal dominant, which means it is transmitting from both the parents, but only mother is transmitting the disease to her children. That's why it is mitochondrial inheritance. Now, which of the following statements regarding mitochondrial inheritance is false? Now, affected males do not transmit the disease. Yes, we all know this. Affected males do not transmit the disease. No. Clinical disease always appears if the mother is affected. No. See, there are certain important things. There are two important things that we need to know regarding this mitochondrial inheritance. Number one is the threshold effect. There is something called the threshold effect, right? Remember that this mitochondrial gene has to be mutated. Mitochondrial gene has to be mutated, and that mutated mitochondrial gene has to be transmitted to the progeny for the disease to occur. But there is another important thing. The amount of a certain amount of mutation, the amount of mutation that is actually transmitting to the child has to cross a certain limit, has to cross a specific threshold, has to cross a specific threshold to cause disease, right? Small amount of a little amount of mutated DNA is transmitted, no, it won't cause the disease. It has to cross a specific threshold, and that threshold is different for different diseases. Okay, this is known as threshold disease. So if we have a look into this second option, clinical disease always appears if the mother is affected. No, it has to cross the specific threshold, then only disease will manifest. Okay, the mitochondrial gene might be mutated, but the disease won't be phenotypically apparent. Okay. And another important thing that we need to know, that is known as heteroplasmy. Every time this fusion takes place between sperm and the egg, the mitochondrial DNA that is transmitted is not equal every time, right? Remember that only, right, variable portion, only a variable portion of the mitochondrial genome is passed to the offspring, right? Only a variable portion of the mitochondrial genome is passed to the offspring, right? This is known as heteroplasmy. So every time if the mother is giving birth to 4 children, over here she has given birth to 4 children, right? All of them have got different portions of the mitochondrial DNA. Okay. So that's why associated with variable severity among siblings. Yes, this is also true statement, and this is explained via this heteroplasmy, right? Because not all of them are getting equal amounts of genetic mutation, okay, in the mitochondrial DNA. So these two things are quite important that we need to know, that this threshold effect and heteroplasmy. Threshold effect means the amount of mutation that is transmitted has to cross a specific threshold to cause the disease, and heteroplasmy means only variable portion, right? Every time a child gets the mitochondrial DNA, a different portion of the mitochondrial genome will be transferred, right? Okay. These two things are quite important for mitochondrial inheritance. Okay. The melos is inherited in the given pattern. Yes, we all know this. Melos is the most classical example. Besides that, we have the Cohen-Sayre syndrome, we have CPEO, right? A lot of other examples are there. Okay. So false statement would be option B. Clinical disease always appears. No, they depend. Now it depends on the threshold. Okay. So option B is our correct answer. Moving on to the next question. Now a 62-year-old post-menopausal woman on HRT presented with abdominal pain for past 6 months. On examination, we have a non-tender right adnexal mass was palpable. USG showed a 3 cm by 3 cm smooth ovarian cyst. What is the next step in her case? Now, before we answer this question, let's have a look into this management of ovarian cyst. What do we do? Management of ovarian cyst. So first thing that we do is divide the patients into two groups, whether she is premenopausal or postmenopausal. Okay. If she is premenopausal, then we have to look into the size. If the size is less than 5 cm, we do nothing. We just wait and watch. Okay. If the size is 5 to 7 centimeters, we go for serial USG follow-up. Okay. And if the size is more than 7 centimeters, we go for surgical removal. Okay, why? Because of an increased risk of torsion. Because of an increased risk of torsion in such a large cyst. But if she is postmenopausal, the size doesn't matter over here. We need to calculate something called the RMI or RMI. RMI has to be risk of malignancy index. Okay, because of an increased risk of ovarian carcinoma in postmenopausal age group. Okay, so what is this RMI? RMI is equal to a USG score times your menopausal status score times your concentration of CA125, right? The biomarker. Okay. What is this USG score? USG score is given as 0 for a benign finding, 1 for a suspicious finding, and 3 for a malignant finding. For a malignant finding. Menopausal score, we get a 1 for premenopausal women and 3 for postmenopausal women. And CA125, the exact amount of CA125 in international units and deciliter. Okay, by international units and ml. What is the significance? Right, remember, if the RMI score is less than 200, we do nothing. We just follow up the patient. Follow up the patient. If the RMI score is more than 200, then we need to confirm the diagnosis. We need to go for biopsy, right? Something like that. Okay. So this is the exact protocol that we follow for management of ovarian cyst. Now over here, it has been mentioned she is a 62-year-old postmenopausal lady. Postmenopausal lady, which means that we have to calculate the RMI. Now RMI mein one menopausal score mein we know that she is postmenopausal. USG is also been done, right? And the thing that is left is CA125 component. So yes, we need to go for CA125 estimation. Okay. If it is normal, advise regular follow-up, of course. Reassure, and if you look into the other options, reassure and advise regular follow-up once in 6 months. This would be done in a premenopausal lady. Okay. Exploratory laparotomy for evaluation of the cyst and confirmation of the USG. These things would be done when the RMI is more than 200, when we are trying to manage the patient, right? When we are trying to confirm the ovarian cancer. Okay. So option D should be a correct answer over here. Okay. Moving on to the next question. Sorry. A 2-year-old child with known sickle cell disease. Presents with sudden pallor, tachycardia, and massive enlarged spleen, which is palpable 6 centimeters below the costal margin. Now, lab report shows hemoglobin of 4, reticulocyte count of 15%, nucleated RBCs. What is the immediate management to be carried out in this patient? Now, over here, we have a sickle cell disease patient, and there is sudden pallor. There is sudden pallor, sudden drop of hemoglobin to 4, and we get a reticulocyte count of 15%, which means that reticulocytosis is present. Reticulocytosis is present over here, which means that the bone marrow is functioning normally. Okay. And we have a massively enlarged spleen. Sudden pallor, massively enlarged spleen in a very young child, of sickle cell disease. This is a very characteristic presentation of something called the acute splenic sequestration crisis. Okay, that is ASSC. Acute splenic sequestration crisis, which has resulted in this massive splenomegaly and sudden drop in hemoglobin. This is the body is trying to compensate with the reticulocytosis component, is usually seen in children less than 5 years, right? Less than 5 years before autosplenectomy takes place. Before autosplenectomy takes place. Okay. So what do we do over here? We go for this urgent volume expansion and cautious transfusion, right? Because this is associated with hypovolemic shock. And why do we need to go for this cautious transfusion, right? Even though the hemoglobin is 4, we are going for cautious transfusion because of an increased risk of hyperviscosity in such a child, right? Because he is already suffering from sickle cell disease. Urgent erythropoietin administration. See, erythropoietin will increase your hemoglobin, but it has a very slow action, right? And moreover your bone marrow function is normal. There is proper reticulocytosis that is occurring as a compensation for the sudden drop in hemoglobin, right? Erythropoietin would increase your bone marrow functioning, but the bone marrow functioning is already normal, so it's no use over here. No, it's useless to provide erythropoietin. IV fluids and morphine. This is IV fluids and morphine is actually given in a vaso-occlusive crisis of sickle cell disease, not in ASSC. Okay. And steroid therapy has no role. So this is something that we need to know. Besides vaso-occlusive crisis, there is another crisis called the acute splenic sequestration crisis in SCD. Okay. And this is the classical presentation. Okay. Moving on to the next question. Now neonate, excuse me, a neonate was brought with the features of lethargy and poor oral intake. On examination, a specific finding was found as shown in the image below. Urine Benedict's test was positive but negative for glucose. Which is the enzyme? What is the enzyme deficiency in this condition? So over here we can very well appreciate this is the oil drop cataract. This is the oil drop cataract and this is pathognomonic. This oil drop cataract is actually pathognomonic of galactosemia. Moreover, we have this urine Benedict test positive, right? We all know that it is positive for reducing substances, right? And it is negative for glucose. Why it is negative for glucose? Because it is the galactose component, which is causing this positivity. Okay. Now we all know, okay, galactosemia. Now which enzyme is deficient? So we can directly rule out hexokinase and phosphofructokinase. Okay, because they are not involved. Now galactokinase causes the type 2 galactosemia, galactokinase deficiency, and galactose 1 phosphate urine transferase causes type 1 galactosemia. How to differentiate between type 1 and type 2 galactosemia? Remember that this cataract component is present in both of them. The cataract component is present in both of them. But remember that this systemic symptoms is absent in type 2, whereas systemic symptoms are present in type 1. And the question does mention about lethargy, about poor oral intake, right? These systemic symptoms are present in this child. So it should be a type 1. It should be a type 1 galactosemia. So our answer should be option C. Okay. There is another type called the type 3. There is another type called the type 3 galactosemia. Right? In type 3 galactosemia, your UDP galactose epimerase is deficient. Over here also we get systemic symptoms. But in a in a mild form, right? It would be much milder than type 1. Okay. So over here option C should be our answer. Okay. Just a second. Sorry for the pause. Moving on to the next question. A 28-year-old female presents with bruising and epistaxis. Lab report mein we have hemoglobin of 8 grams per deciliter, WBC of 1.5 into 10 to the 9 means 1500, platelets of 20,000. PT and APTT are prolonged, fibrinogen is low, peripheral smear is shown in the image below. Which of the following immunophenotypic profile is most characteristic of this condition? So over here we have pancytopenia. And we have a DIC like picture. And in this image we can very well appreciate multiple OR rods. And this is a fagot cell. And we all know this fagot cell is actually seen in AML, M3 or APML. Acute promyelocytic leukemia, right? Because of the proliferation of the promyelocytes. Okay, now, so we need to know the immunophenotypic pattern of the markers. Remember, the most important among AML that the most important type of AML that we need to know is AML M3. Okay, AML M3 ki har ek cheez yaad rakhni ki hai. Right, APML, if we talk about the APML markers, there are certain markers which are positive, there are certain markers which are absent. Right, remember that the CD13, CD33, which are actually the markers of myeloid lineage are of course positive. Besides that, your MPO and CD117 are positive. And negative mein, yes, something that we need to remember, CD34 and HLA-DR is absent in APML. This is something that we need to remember. Okay. So our answer should be option C. CD34 absent, HLA-DR absent, CD33 positive, CD117 positive. If we look into the other options, CD41 and 61, these are quite specific. These are quite specific to AML M7. That is megakaryocytic. CD 1333 again myeloid lineage, and 14 and 64 are actually markers for macrophage and monocytes. So they would be positive in AML, M4 and M5. Okay. And 34 positive, HLA, DR positive. If these two are positive, we can rule out APML. Okay, we can rule out APML. So our answer should be option C. Okay, these markers are quite important to remember. Okay, moving on to the next question. Match the following with respect to the Wolstein's classification of tympanoplasty. Now this classification, type 1 to type 3 की जो classification है, Wolstein's classification, this is as per the location of the graft. Right, and remember that from type 1 to type 5, the severity of the disease actually increases. The severity of the disease increases, and we place the graft medial every time. From type 1 to type 5, the location of the graft passes from lateral to the medial direction, right? The location passes from the lateral to the medial direction. Okay. Now, if we start from the lateral most structure, the lateral most middle ear bone is actually malleus. Then we have incus, and then we have the stapes. So type 1 we would place the graft over malleus, in type 2 we place it over incus, and type 3 we place it over the stapes superstructure. Okay. Now what happens when the stapes superstructure is also destroyed? Here the footplate of stapes is present. Your footplate of stapes, the footplate of stapes is present over oval window. Now two things can happen. Right, two things can happen. Whether the footplate is mobile or fixed. Now if the footplate is mobile, what do? We actually place the graft over the round window. And eustachian tube. Normally what happens when sound comes, it creates a pressure wave. This pressure wave has to travel. So this pressure wave actually pushes the oval window, pushes the stapes, and the stapes pushes the oval window, and the round window bulges, and this allows the transmission of the pressure wave in the allowing the cochlea to stimulate. Okay. Now what we are doing, we are actually placing the graft over the round window. Now the sound is striking the round window, and the round window is getting compressed, and the oval window gets bulged. The thing is, the direction has changed, but it is still stimulating the cochlea so that we can hear. Okay. We are just changing the direction. This exact procedure is our type 4 tympanoplasty. Okay, where the direction is reversed, but we can still hear. But if the footplate is fixed, and we place it over round window, then the pressure wave won't get transmitted. Of course, in a closed cylinder, how can pressure wave transmit? Okay. So if it is fixed, we move more medially, and we place it over the lateral semicircular canal, and this is known as type 5 tympanoplasty. Okay. Directly over the lateral semicircular canal. So if you move on to the table, type 1 is over the handle of malleus, type 2 is over the incus, type 3 is over stape superstructure, type 4 is over eustachian tube and round window mostly, and type 5 is over lateral semicircular canal. Okay. So it should be A3, B2, C1, D5 and E4. Option B should be our correct answer. Okay. Moving on to the next question. Now, a 28-year-old male from an endemic area presents with paroxysmal nocturnal cough, wheezing and weight loss. Lab reveals massive eosinophilia of 12,000 per microliter and extremely high serum IgE of more than 10,000 international units per ml. Peripheral blood smear mein the microfilaria at 11 pm is negative. What is the most likely diagnosis? So, since we are dealing with microfilaria, endemic area means it is endemic for filariasis. It is endemic for filariasis. Okay. So in a filariasis patient, we are getting paroxysmal nocturnal cough, wheezing, increased eosinophils, increased IgE. So this is actually a hypersensitivity reaction. Okay. Hypersensitivity reaction in filariasis, and in peripheral blood smear we are getting microfilaria to be negative. Why negative? Because they are actually trapped. They are actually trapped in the lungs, and this is resulting in the hypersensitivity reaction, and this particular characteristic condition is known as tropical pulmonary eosinophilia. Okay. If we talk about the other options, Loeffler syndrome has a similar presentation. We actually get similar clinical features, but Loeffler is classically described. It is actually milder as compared to tropical pulmonary eosinophilia. Loeffler is classically described to be caused by ascariasis. ठीक है, can be caused by any parasite, but ascariasis is the most classical description. ठीक है, acute filarial lymphangitis and acute filarial in acute filarial lymphangitis we would get limb swelling, we would get the component of fever, we would get pain, right? Nothing has been mentioned over here, right? So we can rule that out. And bronchial asthma to just left because the presentation is like bronchial asthma, that's why the option is given, it is way out of the picture. Okay, option C should be a correct answer. Answer should be tropical pulmonary eosinophilia. This is the characteristic presentation. Okay, moving on to the next question. 10-year-old child was treated for scabies with 5% permethrin. 2 weeks later, the generalized itching has resolved, but extremely itchy reddish brown nodules persist on the penis and scrotum. What is the most appropriate next step? Now, this is a very classical presentation where in a child we are treating scabies, we gave 5% permethrin, the generalized itching stopped, and then we get persistent itching and nodules on the penis, on the scrotum, in the groin area, in the axillary area. This actually is the classical description of something called the, nodular scabies. Nodular scabies. What happens in nodular scabies? We have given this 5% permethrin. This 5% permethrin has actually killed the mites. What happens in a bacterial infection? Our body's macrophages can actually remove them, but mites are quite large. So they are not that easily removed. So our body actually sets up a hypersensitivity reaction against the dead mites, and sometimes even the eggs of the mites, sometimes against the eggs of the mites. Okay, and this is especially seen in the genitals, in the groins, in the axilla. Okay, in those areas we get brownish nodules and the itching persists. The generalized itching stops, but this itching in this specific areas persists because it is a hypersensitivity reaction. So what should we do? Since it is a hypersensitivity reaction, we need to go for steroids, we need to go for topical corticosteroids or intralesional triamcinolone. Repeat the course of permethrin? No, this won't make any sense. Permethrin is actually repeated when new burrows are seen, when new burrows are seen, or if the persistent itch, the itching is persistent. Okay, actually there is a gap over here. 2 weeks later the itching started, localized to certain areas. That's why it is nodular scabies. Griseofulvin is antifungal, no role over here. And perform a punch biopsy to rule out histiocytosis X. No, histiocytosis X is Langerhans histiocytosis. We do not need to go for punch biopsy, right? Nodular scabies is a clinical diagnosis. Okay, so we directly go for topical steroids. Okay, moving on to the next question. Right, where is the nucleus of the cranial nerve? Where is the nucleus of the cranial nerve supplying the muscle marked as 2 located? Okay, so this is our 2. We all know, so let's try to identify all of them. We all know that 6 is superior rectus and 3 is inferior rectus. These are the easiest one to identify. Okay, then the one over here, so one over here, actually the muscle is turning via a pulley, so this is superior oblique because the pulley is present, Okay, and 4 is our inferior oblique because it is originating from this maxilla in the floor of the orbit, the maxilla over here, right? And then it is inserting into the eye. Now we need to decide what 2 and 5 by lateral or medial, right? Remember there are 2 hints in this picture. Number 1, this pulley is actually on the medial side. And moreover, and the second hint is this inferior oblique. Inferior oblique attachment is from medial to lateral. It originates medially. In the floor of the orbit, and then it travels laterally. To get attached to the eyeball. Okay. So inferior oblique travels from medial to lateral direction. So with both the hints, 2 is medial rectus and 5 is lateral rectus. Okay. Now, what is the nerve supply? We all know the mnemonic, right? LR6, SO4, R3. Okay. So MR falls in R3, remaining 3. So MR is actually supplied by the third cranial nerve. And we all know that third cranial nerve is at the level of superior colliculus. Okay. Superior olivary mein we have the auditory tract. Inferior colliculus mein we have the fourth nerve. Right, which supplies the superior oblique. And facial colliculus mein we have the 6th nerve, which supplies the lateral rectus. Okay. This identification of the muscles is most important. Just remember that the pulley for superior oblique would be on the medial side. Okay. With that we can make that out. because the most difficult to identify is medial rectus and lateral rectus. How to identify medial and lateral side, right? Just remember that the pulley would be on the medial side. Okay. Moving on to the next question. A hypertensive patient with chronic kidney disease was having frequent attacks of renal colic. So the following diuretics is used in this patient. Remember that frequent attacks of renal colic in such a patient is actually due to renal stones. And renal stones is most commonly due to calcium oxalate or calcium phosphate. Okay. If we look into the options, furosemide actually increases calcium excretion. This would rather increase the risk of renal stones. Hydrochlorothiazide, it decreases calcium excretion. Decreases calcium excretion. This would decrease the risk of renal stones. Okay. So hydrochlorothiazide should be the diuretic of choice in such a patient. Mannitol is actually not used. In such cases, right? It is used in increased ICT and acute glaucoma. And spironolactone actually, see, first of all, it has no effect on calcium. Moreover, it increases the risk of hyperkalemia, right? Because it is a potassium sparing one and the patient is actually suffering from CKD. That's why we will never use spironolactone in such a patient, right? We would try to avoid spironolactone in such a patient, right? Okay. Because of an increased risk of hyperkalemia. So option B, hydrochlorothiazide, a thiazide diuretics should be our answer. Okay. Moving on to the next question. Now, a 28-year-old female presents with chronic pain and swelling around the knee. The X-ray is shown in the image. Below. What is the most likely diagnosis? So in this X-ray, we can very well appreciate that it is a eccentric lytic lesion, right? Which is located at the epiphysis and is also involving your metaphysis. And we get a characteristic soap bubble appearance. So this characteristic X-ray finding in a 20 to 40 year individual, especially in a female, because females are affected more than males, right? The diagnosis is without doubt giant cell tumor. We get an eccentric lytic lesion originating in the epiphysis involving the metaphysis as well, showing us a soap bubble sign in a 20 to 40-year-old individual, more commonly in a female, is without doubt giant cell tumor. Okay. So answer would be option D, right? And if we go for a biopsy, we would get multinucleated giant cells. Okay. These bone tumors are extremely important from examination point of view, right? We will try to make a separate PYT MCQ discussion video on bone tumors. But right now, the answer would be option D. And with this question, we come to the end of our discussion on our mixed bag MCQs. If you like this video, consider subscribing to my channel, and thank you for watching.